talks. I gave the talk on Saturday, Meet the Expert session on the updated guidelines for cholesterol management from the American College of Cardiology and the American Heart Association, which I was part of, and to compare them to the American Diabetes Association recommendations for lipid management. So there are a lot of similarities between those two guidelines, and there are a few subtle differences, but basically the statin indications are agreed upon by both organizations, and the intensity of statin therapy agreed upon by both organizations. The lifestyle management in terms of dietary patterns and physical activity agreed upon by both organizations. Subtle differences in terms of cholesterol intake and omega-3 intakes and things like that that there's not substantial evidence for or against, but not harmful, so that's a small deal. Well, of course, the dietary cholesterol could be an issue, but I think that remains to be proven. We're talking about egg yolks and organ meats and things like that. And then the only major disagreement, I think, is in the idea of using the risk calculator. So the American College of Cardiology and American Heart Association came up with a way to use a smartphone to ultimately download data on a patient and ultimately determine his or her need for statin therapy. The AHA and ACC really have developed this as a proof of principle that you can apply that in the clinic and predict risk, where the ADA didn't feel like that had been adequately tested. The ATP 1, 2, and 3 guidelines for cholesterol lowering have been present and evolving over the last 2 decades. So the last update was in 2001, so beginning in the late 2000, 8 to 10, the last part of that initial decade of the 21st century. The National Heart, Lung, Blood Institute, this was a government process, Health and Human Services, NIH, National Heart, Lung, Blood Institute, time to update the cholesterol guideline. In addition to update the hypertension guideline and update the obesity, overweight guideline, and 2 new work groups, lifestyle, which I co-chair with John Jakisik from Pittsburgh, and risk assessment, which was a data drilling process to find out what risk factors are important for cardiovascular disease. Anyway, to cut to the chase, after about 4 to 5 years of hard work, the government decided it was no longer in the guidelines business. So we abandoned a process that had been drafted and re-reviewed and reviewed and re-reviewed multiple times. And then the American College of Cardiology and AHA stepped up and said, we're willing to take this on. And then they reviewed it again. So, but keep in mind the transition between that June 20th, 2013 decision and the ACC and AHA picking that up and ultimately presenting it at scientific sessions in November 2013 was 5 months. So that was really a big effort on the part of those professional organizations. Now the hypertension guideline didn't want to go to the AHA and ACC, and they published that report separately. And the obesity overweight guideline was endorsed both by the ACC and AHA and also by the Obesity Society. So we saw 2 of those 3 major updates go through the ACC and AHA, whereas 1 went tangential. Well, I think what it does is give an evidence-based reason for making decisions clinically. So we would all agree that a healthy lifestyle is important, a good diet and good amounts of physical activity if you could do it. And then there are 4 statin groups: people with existing cardiovascular disease that's atherosclerotic in nature, heart attack, stroke, abdominal aortic aneurysm, peripheral vascular disease. Second indication, an LDL above 190, those people need to be treated. Adult age, of course, 21 to 75. The third is diabetes, and between the ages of 40 and 75, we felt the evidence was strong to indicate patients with diabetes should be on a statin, at least a moderate dose. And then the 4th indication was the risk estimator, which in fact, again, remember the ADA didn't endorse, but the American Heart Association felt that if your risk was above 7.5% for 10 years, the evidence was in benefit of being on a statin rather than not being treated. I think what we're dealing with here is now a trial that just was published this week called Improve It, which showed that ezetimibe in addition to a statin was more beneficial than placebo. So now we're looking at a tiered level of LDL. And keep in mind, one thing that was very controversial about the guideline was the fact that levels of LDL cholesterol of 160, 130, 170 were dismissed because the trial designs didn't target the outcomes based on levels of LDL. But in reality, all of us, well, I shouldn't say all of us, many of us who do a lot of lipid-related medicine set goals for our patients. And even though I'm on the guideline saying it's not evidence-based, we have to take care of patients. And I think the idea of having a sense of how the guideline relates to goal-setting behavior is not inappropriate for clinical care. So, evidence-based guidelines are meant to inform, not to mandate. And then when new trials are available, updates are appropriate, but also clinical decisions need to be made based on those existing trials. What the process is going to be at the ACC and HA now for updating guidelines based on the Improve It trial. And now you may know that this whole new class of cholesterol-lowering drugs is going before the FDA this week, the PCSK9 inhibitors. And that's going to be a big deal because we don't have evidence-based reports yet about the benefit, although the hint is that they will be beneficial, but we don't know yet. So there's lots of unanswered questions, but updates of guidelines are appropriate when the data are available. And whether they're going to wait now for this PCSK9 trials to complete, which will be a couple more years, or they're going to think ezetimibe study is enough to update the guideline based on that, is information I just don't have, and I don't know that anybody really knows that. I think it's incredibly important. When I had the privilege of serving as president of the AHA, it was a good time in terms of the National Heart Lung Blood Institute, NIDDK, the AHA and ADA starting to amalgamate momentum moving forward is a joint venture for metabolic diseases and cardiovascular disease. I think that can still occur and does occur, but I think for the ADA to say the ACC-AHA evidence-based guideline is not worth anything would be not in the best interest of the care of patients with diabetes, or even in the absence of diabetes or at risk for diabetes. So that doesn't mean we twisted their arm. It's just that I think the ADA carefully considered that the guideline was a very strong document, and then patients with diabetes ultimately fit into it reasonably well. The risk estimator might be the only thing that there would be an exception.